Welcome to today's PerfectServe webinar, Making Sense of MACRA. My name is Richard, and I'll be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to the computer screen as we cover the web form platform functionality. Please note that you may need to zoom in out from your browser to see everything. In the middle of your browser, you will see a box containing today's slides. They will advance automatically throughout the presentation. To the right of the slides, you will see a Q&A box to submit a question at any time. Your questions will be addressed during the Q&A portion at the end of the presentation. To the left of the slides, you will find a webcast help icon for technical assistance, as well as a resource list containing a PDF of today's slides and a few other helpful resources. If you are on the phone line but are experiencing any technical difficulties accessing the web portion, please let us know by sending an email to webinars@perfectserve.net. At this time, I will now turn things over to today's moderator, Heather Dorsett, Director of Marketing with PerfectServe. Heather, you may begin.
Thank you, Richard. Welcome, everyone, to PerfectServe's Thought Leadership webinar series. I'll be your moderator for today's event. Before we get started, just a few items to note. We are recording today's webinar for our friends and colleagues who are unable to join us, so that will be available after the webinar today. As an audience member, you are in listen-only mode, so please use the Q&A box to communicate with our speakers or with me today. At the end of today's event, we'll ask that you complete a short survey that will appear in a separate browser window, so be on the lookout for that. And finally, if you hear something interesting today, we definitely encourage you to tweet using hashtag #PSWebcast. You'll see a streaming social post box located in the right of your screen under the Q&A. So if you want to tweet with us, we encourage you to do that. As most of you know, MACRA is a reality, and while most expect to participate, strategies for doing so vary. The goal of speeding up the transition to value-based care is certainly key to the larger mission of improving health care for all populations. 2017 has been designated as the first reporting year, and we know challenges exist, like which and how many measures to report, ways to compile the metrics to submit, and of course care coordination, which ranks among the top of these challenges per a recent Health Catalyst poll. Today's presentation will hopefully offer clarity around which reporting path is right for you and your practice, and we'll share ideas to help you keep pace and evolve. It is my pleasure today to introduce our speakers. We have Kaitlyn Greenbaum, is the Director of Health Policy and Strategy with the Health Management Academy. She brings a wealth of experience in public health and health policy and research, and Kaitlyn is a graduate of the Harvard School of Public Health. Alongside Kaitlyn today is McCleery, the Vice President of Product Management at PerfectServe. Michelle will share how PerfectServe aids clinicians in maximizing operational efficiencies and improving care coordination. And now I'll pass things over to Kaitlyn to get us started. Kaitlyn?
Great. Thank you so much, Heather. So my plan for the next 30 minutes or so I'll talk kind of at a high level about the structure of the MACRA Quality Payment Program, and then talk a little bit more, as Heather said, kind of about what 2017 looks like. So what do you need to think about reporting? What do you need to think about doing? Before we jump into MACRA, just a quick poll. So thinking about your practice, how would you describe kind of your participation in value-based payment models? So close to a 5 would be, you're actively participating in ACOs or bundled payment models or other payment models, or kind of actively seeking these opportunities, and close to a 1 would be, straight fee-for-service, and you haven't really started thinking yet about, participating in these kinds of value-based models. So I'll give you just 20 seconds or so to click on your answer. So looking at the results coming in, most folks are kind of hovering very slowly to moderate, but very few have kind of clicked on that very quickly, that you're kind of actively seeking those opportunities or currently participating in those kinds of models, which is kind of right on track with what I've seen, with what my organization has seen. So my organization typically works with these large integrated health systems. So if you think about kind of this shift from volume to value-based care, it's these health systems, these large health systems that are kind of what you'd imagine to be the driving force, kind of moving the fastest. And even these folks, you can see based on their results, most are really kind of in that very slowly moderate. Even of these kind of large health systems, very few are moving very quickly. But when you think about MACRA and the quality payment program, I think that's really kind of going to be the driver for people moving more aggressively. There are a whole host of carrots and sticks that are built into this system, where it's really going to incentivize providers, both large and small, to kind of move more towards these models in the next couple of years. So just by way of quick background, so the legislation, the MACRA legislation, passed in April of 2015. So this is the legislation that repealed the sustainable growth rate, so everybody was really excited when this passed. And then they saw the proposed rules come out in April 2016 and were a little bit less excited, reading about all of the complexities of this new system. And then the final rule came out in October of 2016, which, as I'll talk about, kind of tempered the requirements, at least initially. So the first performance year began January 1st, 2017. So we're in MACRA. MACRA is being implemented currently. Certainly not a reason to panic yet if you've not thought about MACRA, if you don't know what you're reporting yet. So 2017 is the first kind of performance period, but you're not responsible for actually reporting any data until after the year, so the first couple of months of 2018. So there's still, plenty of time to learn about what you need to do and learn about what you need to report. One of the major questions that my team always gets around MACRA is, with the new administration, with the new HHS secretary, what's going to happen with MACRA? Is it going to stay around? Is it going to be repealed? Is it going to be completely changed? Well, so MACRA was strongly bipartisan. You can see, passed the House, passed the Senate, huge bipartisan support. It was actually a Republican-sponsored piece of legislation, which, Tom Price, the new HHS secretary, was in favor of as well. So generally, MACRA is not going anywhere. It's kind of the key takeaway. Structurally, I don't think there are going to be any major changes from what we'll walk through today. Details of the program perhaps probably changes, but kind of at a high level, the structure of MACRA, it's not going anywhere. So if you kind of think about MACRA, I'd say the one kind of key takeaway is that physicians' reimbursement are going to be variable based on performance, kind of regardless of how you practice. So if you're in fee-for-service, if you're practicing in one of these value-based models, your reimbursement is going to be variable based on performance, kind of regardless of where you sit. So looking at kind of a high-level structure of the MACRA quality payment program. So there are 4 tracks or participation categories. The 2 on the end, so the MIPS and the advanced APM, those are the primary tracks in MACRA. And then the 2 in the middle are kind of these bridge areas, which I won't spend too much time on, but I'll touch on kind of as I walk through. But kind of this MIPS world on the one end and the advanced APM world on the other end are kind of the 2 primary ways that you can participate in the MACRA quality payment program. So MIPS, it stands for the Merit-Based Incentive Payment System. Long acronyms everywhere. You don't need to know, what it means, but basically MIPS, you can equate that with fee-for-service. So if you're a physician and you're practicing largely in fee-for-service, so you're not, in ACOs, you're not in bundled payments, you're just straight fee-for-service, MIPS is going to be applicable to you. So what the MACRA quality payment program does is it established kind of a whole new set of rules, so kind of a new bureaucracy for how you're measured based on performance if you're practicing in fee-for-service. On the other end of the spectrum is this advanced APM track. So you'll land in this track basically if you're participating in alternative payment models, so value-based payment models that take on enough downside risk and you're participating enough, so you have enough of your patients flowing through these models. So if you do land in this track, not many people are going to land in this track initially, but if you do land in this track, there are significant benefits. So if you land in this advanced APM world, basically all of the kind of reporting and all of the bureaucracy of MIPS doesn't apply to you at all. And there are also financial incentives for participating in advanced APMs. which I'll walk through later as well. So these are kind of the two primary tracks, MIPS for fee-for-service, advanced APMs, which gets you out of MIPS. And I'll start by kind of walking through the structure of the MIPS program, since again, this is kind of where most folks are going to land, at least initially, at least in the first, couple of years. So there's a lot of text going on in this slide, but if you really kind of focus on the 4 arrows on the left, those will walk you through kind of what the flow, what the structure of the MIPS program looks like. So the first arrow, so your performance is going to be measured, and that's not, a whole lot different from how your performance is currently being measured. So there, the three major programs that are going on now. So there's the Meaningful Use Program, the EHR Incentive Program, which I'm sure most folks on the line are familiar with. There's PQRS, the Physician Quality Reporting System, which also I'm sure most people are familiar with, and then the Value-Based Modifier System program, which I think fewer folks are familiar with, but that's the one that's kind of looking at quality as well as cost. So there are these three systems, ongoing systems. So essentially these go away. So after the 2016 performance year, actually, you no longer have to report quality. You no longer have to report meaningful use through these existing systems. So last year was kind of the last year that you have to worry about PQRS and meaningful use. However, a lot of the same kind of reporting is kind of filtered through this new MIPS structure. So instead of reporting to these, individual programs, all of it is now kind of under one umbrella, which is MIPS. So under MIPS, there are 4 weighted performance categories. So there's quality, cost, advancing care information, which is really kind of a new way to say meaningful use. It's very similar to what meaningful use used to look like. And then there's improvement activities, which is kind of the only really new component that you'll be measured on. And improvement activities is kind of around care coordination activities. So MIPS, you have 4 weighted performance categories, and you can choose how to report. You can choose how to participate in MIPS. So you can choose to report as an individual, or if you're part of a group, if your group, is practicing all under one TIN, under one taxpayer identification number, you can choose to all report as a group. So what that means is individual, it's kind of straightforward. So as an individual, you report all of your activities, report all of your data to CMS individually at the end of the year. If you choose to report as a group, basically all of your performance is aggregated. So it's basically averaged across all of the clinicians in the group. You report once in each performance category to CMS, which incorporates data from everybody in your group. And then at the end of the year, you're judged based on the group performance, not on your individual performance. So there's a 2-year look back. So as was mentioned, 2017 is the first performance year, but this doesn't impact your payments until 2019. So for 2018 performance, that would impact your payment in 2020, et cetera. So you have your 4 performance categories, and then you get a score. So you get a score on each performance category, and those are aggregated. So at the end of the year, you'll receive kind of a composite score or a final score from 0 to 100. So if you choose to report as an individual, you as an individual clinician will get your, individual score from 0 to 100. You and your partner in your practice could have completely different scores based on your own performance. But if you choose to report as a group, everybody in the group ultimately is going to receive the same score. So there's going to be no differential between the clinicians in your group if you choose to report as a group. So, if you have 2 clinicians in your practice, one is a very high performer, one's a very low performer, you kind of have to think about the dynamic of how you want to report. So that's kind of one of the choices that you're going to have to make as a practice at the end of the year. The other thing I'll mention about these scores is they are going to be public scores. So your score from 0 to 100, either as an individual or as a group, you'll be able to pull that up on CMS's website, which may be picked up by, Yelp or ZocDoc or any other websites that are out there. So it's an important score beyond just, influencing your payment 2 years later. It's an important score because it's going to be a public score. So your performance is going to be measured. You're going to get your score at the end of the year. And then every year, CMS is going to set a threshold comparison. So for the first 2 years, CMS has a lot of flexibility kind of in how they want to interpret and how they want to implement MACRA. But starting after the first 2 years, it's kind of set in stone, and CMS doesn't have that kind of same flexibility. So for the first 2 years, basically how it works is, the threshold is set wherever CMS wants to set it, and then basically your individual score is compared against this threshold, and that's what determines your payment adjustment. So if you score way above the threshold, then you get a very high payment adjustment. If you score well below the threshold, you get a negative payment adjustment. So for the first 2 years, again, CMS kind of has this flexibility to set this threshold wherever it wants. So for 2017, CMS set this threshold at 3 points. So you're going to get your score from 0 to 100, and this threshold is at 3 points. So basically, anybody who scores above 3 points is guaranteed to have a positive payment adjustment. Anyone who scores below 3 points is going to have a negative payment adjustment. So there's a pretty low bar for 2017, 3 points out of 100. So a pretty low bar for avoiding that negative payment adjustment early on. I think I've probably been using physician and clinician interchangeably, but that's accurate. So MIPS MACRA does not only apply to physicians, so it's clinicians as well, which is new from the previous, from meaningful use and from PQRS, where clinicians didn't have to participate. So this is encompassing kind of a broader group of clinicians. So basically, I think kind of the way to think about this is everybody is in MIPS. So MIPS is kind of the baseline track where every clinician is going to land. And there are only 3 ways that you're going to get out of this MIPS track. So the first way is that if you fall below this low volume threshold that CMS set. So CMS set a threshold at $30,000 of Part B charges or 100 Part B beneficiaries. So if you fall below that threshold, so you don't have a lot of, you don't practice a lot in Medicare Part B, then you can be excluded from MIPS completely. So none of this reporting or scoring applies to you. The second way you can get out of MIPS is if you're in your first year of participating in Medicare. So this doesn't include a clinician who then moves to a new group and then is in their first year practicing Medicare in a new group. This is in your first year of ever participating in Medicare. So if you're in your first year, then you kind of get a free year where you don't need to worry about your performance, you don't need to worry about your score, and then you're expected to start participating in the following year. So the third way, the third exclusion to MIPS participation is kind of what I mentioned at this advanced APM track. So if you have enough patients or if you have enough money flowing through an advanced payment model, so a value-based payment model that has enough downside risk, then that gets you out of the MIPS track. So you don't have to worry about reporting or scoring or anything like that if you're practicing. So if you're in an ACO or a bundled payment model or something like that, if you have enough of your money going through those models, then you'll be excluded from the MIPS track. So reporting in 2017, as I mentioned, the bar is very low. CMS set the bar very low in 2017. So basically, as I mentioned, so 3 points is going to be that performance threshold. So if you score anything above 3 points, in 2017, you're guaranteed to avoid a negative payment adjustment in 2019. And that really means anything. So if really you interact with CMS at all in 2017, you will avoid a negative payment adjustment in 2019. So what that means is if you submit one quality measure, and that's all you do. So it could be a quality measure that you do really poorly in, so you have really, poor performance in that quality measure, or you don't even, meet the case minimums, or you don't meet the data completeness thresholds or anything like that. If you submit literally anything to CMS in 2017, then you're going to avoid a negative payment adjustment in 2019. Even given that low bar, there are folks that still aren't going to report, whether, they don't understand or they don't have the technical capability or whatever it is. There are folks who aren't going to report. So if you do, report nothing at all in 2017, then you're going to get the maximum negative payment adjustment in 2019, which is -4%. But again, so it's a very low bar. So you submit anything to CMS in 2017, and you avoid a negative payment adjustment, and you have a chance at a positive payment adjustment. So there are 3 categories where you actually need to submit reporting. So that's the quality, the advancing care information, or this EHR, and the improvement activities. So for each of these 3 categories, a performance period, CMS defines it as 90 days in 2017. So when you submit data at the end of 2017, it doesn't even need to be data that covers the entire performance year. It only has to be data that covers 90 days within 2017. So that kind of goes back to my initial point, which is, if you haven't really been focused on your performance at all, or measuring anything yet, there's still a whole lot of time in 2017 to kind of get your understanding and kind of determine what it is that you want to perform well in or try to perform well in or measure in 2017. So it's only a 90-day performance period within 2017 that affects your score in 2017. So I mentioned the performance categories are weighted. So this just shows what the weightings are for each of the categories, and it changes over time. So in the first year, one of the major changes actually from the proposed rule to the final rule is that CMS eliminated the cost category just for 2017. So for 2017, quality is going to be 60% of your score, so it's going to be really the main driver. Advancing care information, this EHR meaningful use category is going to be 25% of your overall score. And improvement activities, this kind of care coordination component, is going to be 15% of your overall score. So this cost category is going to start, it'll come in the 2018 performance year at just 10%, and then it'll increase to 30% in 2019. So as I mentioned, 2019 is kind of when the legislation kicks in, so CMS doesn't have a whole lot of flexibility left in 2019. So these are the weightings that are going to kind of go on ultimately after 2019. So kind of the final weightings are ultimately going to be 30% cost, 30% quality, 25% advancing care information, and 15% improvement activities. So looking at each of the performance categories, diving in a bit. So quality is really not going to look a whole lot different than PQRS looks now. So if your practice, or if you as an individual, if you've successfully been participating in PQRS, if you have measures that you've been reporting and reporting successfully through whatever mechanism you've been using, not a whole lot is going to change. So if you've been successful, then you will continue to be successful in quality under MIPS. The only kind of difference is that quality under MIPS is supposed to be a little bit easier, and I think it is a little bit easier and a little bit more flexible. So under PQRS, each clinician or each group, you're expected to report 9 measures, and there are specific requirements for what kind of measures you need to choose. But for quality under MIPS, it's only 6 measures that you have to choose. One of them has to be an outcome measure. For specialists, it's a little bit easier to participate in the quality component of MIPS than it was in PQRS. Because each of the measures, there are about 200, close to 300 measures that were finalized in the quality category, but they're organized by specialty. So if you're a cardiologist, you can pull up just the cardiology measures and choose just from that kind of subset of measures. So you don't need to worry about kind of going through the entire list of 300 or so measures and picking which ones are applicable to you. There are also choices of kind of different mechanisms that you can use to report. So you can report through your EHR system if you're technically able to do that. You can report through registries, clinical or qualified clinical data registries. If you're an individual, you can still report through claims if you've been doing that for PQRS. And if you're a group and you've been using the GPRO mechanism in the past, you can still use that GPRO mechanism. So again, kind of the main takeaway I would say for the quality category is if you've been doing PQRS, this is pretty much the same, but a little bit easier. Advancing care information, similar to meaningful use. So I think kind of the same goes that if you've been participating in meaningful use and you've been participating successfully, then you should do fine in advancing care information. Again, the only difference is this is, I think, significantly more flexible than the meaningful use program used to be. So with the meaningful use program, what CMS did is basically set thresholds for each measure. So if you hit a specific threshold for, a certain measure, then you'd be fine. And if you fell below it, even if you were, just a smidge below it, then you would be penalized for that. So the setup is a little bit different here where it's not all or nothing. So for advancing care information, there's a base score and a performance score. So the base score is basically kind of measuring your functionality. So it's basically just trying to assess whether your EHR system is technically able to report on these 5 measures. So for security risk analysis, you basically just attest, yes, our EHR has the, capability to do a security risk analysis. And for the other 4, you basically submit numerators and denominators to CMS. And if you have a numerator of at least 1 for each of these measures, then you check off the base score. So it's kind of, straightforward, can our system do this? Can our system send a summary of care to at least one patient? If the answer is yes, then you automatically earn the base score. So the base score is worth 50 points. It's worth 50% of your score in the category. So that's, a significant number of points right there just for having the functionality to achieve the base score. And then for the performance score, this is basically kind of a flexible opportunity to earn additional points in the category wherever you can. So there are 9 different measures, and you don't need to necessarily report on all of them. You don't need to score perfect performance on all of them in order to do really well in this category. So there are actually 155 possible points that you can earn in this category, and you only need 100 to get the maximum possible score. So there are 55 points that are kind of floating around, which means, again, that you don't necessarily need to have a 100% performance rate on every single measure. You don't necessarily need to report every single measure in order to do really well in this category. So improvement activities is kind of the only brand new way that CMS is going to be measuring your performance starting in 2017. But I would also say that I think this in some ways is kind of the easiest, particularly, if you've focused your organization around care coordination activities or anything like that. So how this one will work, so CMS finalized a list of nearly 100 different activities. And again, these are things all about care coordination, patient-centered care, increased access, things like that. So most clinicians and groups, you're basically going to have to attest to having participated in a couple of these activities. So for most clinicians, it's 2 to 4 activities that you'll need to check off in order to get the perfect score in this category. And it is all attestation. So it's not going to be probably, a heavy burden on each practice to report this. At the end of the year, CMS will reach out, or you'll have to log into a portal and basically check a couple of boxes. For those folks that are participating in patient-centered medical homes or in any kind of alternative payment model, so, an ACO or any kind of, the definition of patient-centered medical home is quite broad. So if you're participating in one of those kinds of models, you automatically get 100% in this category. So you don't even need to report anything if you're participating in one of those models. The group dynamic here is interesting. So there's no threshold, basically. So if you're a group of 10 clinicians, say, and 2 of them are in a patient-centered medical home, then the entire group is going to get credit for that. The cost category. So I mentioned, cost is thrown out for 2017 for everybody. So nobody needs to worry about cost in 2017 impacting your score in 2019. However, it comes in fairly quickly. So by 2019, it's going to be 30% of your score. So I think it's kind of a good opportunity to start getting a better, understanding on what CMS will actually be measuring you on and how you perform relative to other clinicians in the country, so you can start, kind of working towards performing better in this category. So cost is eliminated for 2017, but you still will receive your quality and resource use report next year, which will kind of explain your 2017 practice. So what you'll see in that report, which I think a lot of clinicians or a lot of practices don't necessarily or haven't necessarily paid a lot of attention to in the past because they haven't really impacted your payment before. But for your 2017 report that you'll get from CMS, that'll, I think, give you a very good understanding of where you land on each of the things and each of the measures that CMS will be using and kind of where you land relative to other clinicians in the country. So that'll kind of help you better prepare for the cost category going forward. So special scoring considerations. This is another question that we get asked quite a lot. So there are no kind of special considerations for any specific specialty. So there's no, pathologists don't need to report this, or, there's nothing based on a specific specialty. There are only 3 different categories which will give you special scoring considerations. So non-patient facing clinicians, which are clinicians that are billing 100 or fewer patient-facing encounters to include telehealth encounters. So if you fall into this category, so if you are a pathologist, say, and you fall into this category, then you don't need to report advancing care information. So you're off the hook for that one. And there's also lessened requirements for improvement activities. Hospital-based clinicians, so if you're 75% or more of your services are in a hospital-based setting, advancing care information also doesn't apply to you. If you're in a small group, rural, or geographic health professional shortage area, the only consideration is improvement activities where there's less of a requirement as well. But otherwise, besides these couple of special scoring considerations, beyond these couple of categories, everybody is in MIPS. Everybody is participating in MIPS, every specialty just like any other specialty. So looking at how your payment is going to be adjusted kind of going forward into the future. So as I said earlier, so you're going to get your score at the end of the year from 0 to 100, and there's going to also be this performance threshold that's set every year. So if you land directly at the performance threshold, so in the first year, if you score exactly a 3, then your payment adjustment is neutral, neither positive nor negative. If, say, in 2 years, the performance threshold is set at 60, if you score exactly a 60, then neutral payment adjustment. How it'll work every year is that if you score above this performance threshold, you're guaranteed to get some positive payment adjustment. And then if you score below the performance threshold, then you're going to get a negative payment adjustment. So this first green bar that you see on this slide kind of gives you the general range for kind of where your payment adjustments are going to land based on how you score. So in the first year, you're kind of at risk for plus or minus 4%, 5% the next year, 7, 9, and then 9 kind of continues. The thing that I'll note, so the bottom is set. So the -4, the -5, the -7 is set. So there's no way that you can possibly earn less than that number. However, the top is kind of flexible, and that's because MIPS is a budget neutral program. So basically, whatever dollars land on the bottom, whatever negative dollars CMS gets from the poor performers, it's those dollars that are going to be allocated to the folks on the top, so the high performers. So if it works out that there aren't a lot of dollars on the bottom, probably the first year, because it's very easy in the first year, then there aren't going to be a lot of dollars to distribute to the top. So it's possible that even the highest performer in 2017 is going to earn less than positive 4%. But the opposite is also true. So if it lands that there are a lot of dollars on the bottom, so if there are lots of, high billing specialists that perform very poorly and there are lots of dollars on the bottom, there could be, more dollars than anticipated to distribute to the really high performers. However, that is kind of capped, and that's what that second line is. So the kind of the top line that you're capped at is basically 3x the first line. So the one other thing that I'll mention on this slide, so there's also a pool of money each year for the very high performers. So if you're very confident that, you've been performing very well in PQRS and meaningful use and you think you can score very well in MIPS, there's a chance that you can earn more than whatever would be allocated to you based on this kind of budget neutral methodology. So for the first 6 years, CMS is putting an additional $500 million into a pool, which is just going to be distributed to the highest performers. So in 2017, for 2019 payments, anybody who scores above a 70 is going to be eligible to receive a part of this $500 million pool. So this slide and the next are kind of interesting estimates based on the proposed rule and the final rule. So there are a lot of different accommodations made between the two rules, and the final rule, kind of as I've walked through, has made it a lot easier for clinicians to avoid a negative payment adjustment. So based on the proposed rule, where there are a lot more requirements, you can see on that first line, so solo practitioners were anticipated, 87% of solo practitioners were anticipated to have a negative payment adjustment in 2019. Again, just based on kind of the high requirements that were initially set out in the proposed rule. But to compare that to the new requirements in the final rule, which were lessened quite a bit, so now only, if you look at 1 through 9, clinicians in groups between 1 through 9, only 20%, and that's kind of a conservative estimate, are anticipated to get a negative payment adjustment in 2019. So what that means is there aren't going to be a lot of clinicians who get a negative payment adjustment in 2019 based on 2017 performance. So there aren't going to be a lot of dollars on the bottom to distribute to the folks who do really well. So this is also kind of CMS's anticipation estimates for 2019 based on 2017 performance. So CMS estimates that about 50,000 clinicians are going to get a negative payment adjustment. So 50,000 clinicians aren't going to report anything at all is the estimate, which is going to equate to about $199 million to distribute to anybody who gets above 3 points. So even if you kind of count in this $500 million pool to the really high performers, that's a lot of clinicians and not a whole lot of money to go around. So in the first year, kind of the main idea is there's not going to be a whole lot of risk, but there's also not going to be a whole lot of reward. So I'll just talk very briefly about kind of this advanced APM track. There are significant benefits, as I mentioned, for participating in these advanced alternative payment models. You can see kind of the list on the left are all of the models that are going to count as advanced alternative payment models in 2017. So there aren't a lot, and there aren't a lot of folks participating in these models. So really, kind of initially, most folks are going to be in the MIPS track. However, over time, starting in 2018, there are going to be a couple of new models, and over time, the goal is for, clinicians and specialty groups and, specialty societies to continue to work with CMS to continue to develop kind of specialized alternative payment models that will count for the purposes of MACRA, to get more people out of MIPS and into this advanced APM world where you get, financial benefits and you don't have to worry about all of the bureaucracy of MIPS. So the last thing that I'll just kind of touch on very briefly. So, I mentioned MACRA isn't going anywhere. MACRA is going to stick around, but there is some uncertainty, given the new administration. And I think one of the key areas where there's uncertainty is around kind of what kinds of alternative payment models are going to be implemented in the future. So, Tom Price has said that he's not a fan of mandatory bundled payment models. So, who's to say what he'll do with the model that's supposed to be rolled out, coming soon for cardiac care for a couple of cardiac episodes. And, we'll have to see kind of what he's thinking about, all of these advanced alternative payment models or alternative payment models going forward. So there's a little bit of uncertainty, but I think, the bottom line that I'll emphasize again is kind of the structure, I think, is generally set, certainly for 2017, and going forward, I don't think there are going to be a whole lot of large structural changes to this program. So with that, I will hand it over to Michelle to talk a little bit more about how PerfectServe is working in this area.
Thank you, Kaitlyn. That was very informative. As you had said quite succinctly, that the majority of practices and practitioners are going to fall under the MIPS program, and you reviewed the various parameters that will comprise the composite performance score, noting quality, more of the same, advancing care information, more of the same. Cost, of course, is notable because of the way that you provide care can affect cost, and it will be imperative that you realize cost savings, and that will be primarily derived through your successful management of your chronically ill population. And that is highly dependent upon efficient collaboration and care coordination across multiple disciplines and multiple organizations. The only new category, as mentioned by Kaitlyn, is your clinical performance improvement activities. And this truly was designed to reward those practices who utilize patient-centered approaches to achieve better, smarter, and healthier care. Now, we truly believe that PerfectServe Synchrony can have a direct impact on those last two parameters, your cost and your performance activities. PerfectServe is a care team collaboration solution that consists of secure messaging, web, and mobile applications for physicians, nurses, and the broader care team. And it was intently designed to overcome those recalcitrant communication obstacles that have long degraded and delayed care, such as knowing who to contact for a given situation, or searching and struggling to find contact information, or leaving messages with intermediaries, never knowing if they will deliver the right message to the right recipient, and suspending and disrupting care, waiting for those returned phone calls that sometimes never come. And by overcoming such challenges, that is how PerfectServe Synchrony can facilitate timely patient-centered collaboration across all care team members and all care settings. Now, the way that we accomplish that is through three unique capabilities. One is dynamic intelligent routing, and that is the ability to automatically identify and provide immediate connection to the right care team member for the clinical situation at hand. So for every single communication that occurs, PerfectServe in real time analyzes a combination of all of the situational variables associated with that communication in order to intelligently direct that communication to the right care team member. So it totally eliminates the need to expend any effort in trying to communicate with any other care team member. Now, a second distinguishing capability is Synchronous single cloud-based architecture. So it has the ability to extend dynamic intelligent routing across the entire patient-centered ecosystem, encompassing multiple facilities and organizations, as well as every discipline across the continuum. And this allows PerfectServe to overcome those geographical barriers that constrain those products with traditional client-server architecture. And further, it collapses those entrenched hierarchical barriers that have always impeded communication within care teams, dictating who can communicate with whom and how. That has forever prohibited communication just based on the fear of reaching the wrong individual about the wrong subject. Because PerfectServe always reaches the right individual in the manner he or she prefers. Now, Deloitte recently published an article in regard to the implementation for practices, but also for health systems, because there are several hospitals, of course, that own their own physician practices. And so both really need to determine either how to succeed under MIPS or whether or not to pursue advanced APM arrangements. But regardless of the choice, Deloitte notes that both will require an investment in technology and business practices. So practices and health systems need to start by analyzing their current quality and resource use, and then to determine the changes in practice patterns that are needed, and then what will be the enabling technologies and business practices to support the same. Now, one strategy they offered for consideration, given that the majority will fall under MIPS, is to seek accreditation of those practices as patient-centered medical homes, and to do so by investing in the practice improvement activities in order to receive credit under MIPS clinical practice improvement measures. Now, as Kaitlyn had mentioned, there are 8 today subcategories within this category of improvement activities. The entire inventory as it stands today is printed within the final rule. Just as an example, listed 4 of the different subcategories, and each are associated with example activities. And as Kaitlyn noted, there's over 90 different activities, and there are several that are associated with each of these subcategories. So I just wanted to show you an example of these and how PerfectServe could assist you in meeting these just solely by the deployment of the technology. So for example, in the subcategory of expanded practice access, one of the activities would be to provide 24/7 access to practitioners for urgent and emergent care. Well, PerfectServe Synchrony offers after hours and 24/7 answering services or call management services for all practices. And in that way, all incoming communications to the practice are automatically and intelligently routed to the right individual. If a patient should call needing to connect directly with a practitioner, for example, then that patient's call will immediately be routed to the right on-call physician or practitioner who is able to assist that patient at that moment in time. In addition, other activities within this subcategory include utilizing alternative care models, such as virtual visits, phone visits, home visits, setting up visits in alternative locations like city centers, for example. And for all of these, PerfectServe is able to support and facilitate the same. Second category, as another example, is population health management. And truly, this entails collaborating with your key partners and stakeholders, particularly targeting specific chronic conditions, but also being able to effectively manage transitions and referrals across multiple organizations and disciplines. In addition, another activity within this subcategory is to provide routine follow-up to hospitalizations, ED visits, and other types of stays. PerfectServe offers automatic patient transition notification. So if a patient, for example, was admitted to the ED, then an automatic notification could be sent to the primary care physician, any other of the broader care team members that are located in other facilities and at different care settings. So everyone would be apprised of the patient's condition and can ensure that the patient will follow up as needed. A third category is care coordination. Again, really entailing the need to have that timely communication and collaboration and manage effectively your care transitions and to ensure bilateral exchanges of necessary patient information. And in that regard, we know that hospitals as well as practices work with other facilities and organizations within their network who may or may not share the same EHR, but they definitely work with other organizations and facilities that do not share their EHR. And in this case, it's PerfectServe Synchrony that can transcend the disparate EHRs in order to ensure that there is that timely bilateral exchange of patient information. Another example of an activity within the care coordination subcategory is timely communication of abnormal test results. And because PerfectServe Synchrony is able to integrate directly with the source system generating those results, then we can intelligently and dynamically deliver the same to the right practitioner physician who is able to accept those results and act on them if needed at that very moment in time. And as I said, I don't have the time to review every single category, but in looking at the categories, most entail that need of timely communication and collaboration. As an example, integrated behavioral and mental health, you might think, how does that really apply to PerfectServe? But one of the activities is the regular communication and coordination between primary care and behavioral health. And of course, hopefully, as you've seen, that PerfectServe Synchrony can play a very significant role. And really, that ability to facilitate timely collaboration across the entire care team and all the various care settings. And another suggestion by Deloitte was, while within the MIPS program, consider building and acquiring those special capabilities to exceed under the advanced APM. And they mentioned such activities as building networks that would also include your post-acute care providers, integrating healthcare IT, and this is beyond your EHR, across clinicians and health systems to truly support collaboration, and then working efficiently with clinicians to decrease costs and improve quality. And once again, PerfectServe Synchrony being able to facilitate that timely patient-centered collaboration regardless of the care setting and inclusive of all care team members can support this transition to an advanced APM as well. So at this time, both Kaitlyn and I would be happy to entertain any questions that you may have.
Thanks to Kaitlyn and Michelle. Really, really good information. And we do have several questions here in the Q&A box, so let's get started. I think this one is for Kaitlyn. How many improvement activities does a physician have to do to receive the minimum score for the reporting year 2017 just to avoid the penalty?
Yeah, that's a good question. So for improvement activities, it's just one. So if you look at a list of all of the improvement activities, some are listed as high weighted, some are listed as medium weighted, so they're worth, you know, a different number of points potentially, but you just have to report one improvement activity regardless of the weight in order to receive the minimum score. And as I said, that's the same for quality. You report any one quality measure just to receive the minimum score. And for advancing care information, it's a little bit different. So just to receive the minimum score in advancing care information, you have to achieve the entire base score. So you have to earn all 50 points of that base score to receive the minimum score for your final score.
Thanks, Kaitlyn. So related to that, we had another question for advancing care. Do you have to report on all 9 measures? Is that the case?
You do not. Yeah,
okay.
So you do not need to report on all 9 measures. So you need to achieve at least the one patient for each of the 5 base measures in order to get any score in the category. So if you only, say choose to report on 3 of the base measures, you're going to get a 0 for the entire category. So you have to achieve the entire base score, and again, you'll get 50 points for achieving that base score, the base score. And then kind of beyond that, it's however hard you want to work, or however hard you want to try to kind of max out your score in the category. So there are 9 measures in the performance score. Each of them are worth 10 points. So there are 90 points there. You don't need all of the points in order to get a perfect score in the category. So if there are a couple of measures that, your system can't technically do, you don't have to report them. If you don't think you're going to score very high in performance on all of the measures, you can report all of the measures, and even if you have lower performance, you'll still kind of accumulate points. So there's a lot of flexibility. You don't necessarily have to report on all 9. You can kind of pick and choose, again, kind of depending how hard you want to work for achieving that perfect score in the category. Okay,
great. Thanks. We have a couple of questions around specialties or type of provider, so we'll get to those. This one is there a list of measures for ENT and ophthalmology, and if so, where can we get that?
Yeah, so you can go, if you go on CMS's website, I believe it's just qpp.cms.gov. You can pull up a list by specialty. So, you can see that full list of 300 quality measures, and then if you click on your specialty, it'll just show you the ones that are applicable to you. So if you go on CMS's MACRA QPP website, you'll be able to find all of the measures broken down by specialty.
Okay, great. Thank you. And this person is asking, this person is saying, I am in long-term care as an individual provider and have not done PQRS or have an EMR. How will this impact me?
So if you're not, excluded from MIPS, if you don't meet one of those 3 exclusions, then MIPS does apply to you as a clinician. So if you've never before done PQRS and you don't have an EMR, there's still ways that you can at least achieve that kind of minimum level to avoid a negative payment adjustment. So for example, some of the quality measures, as an individual, you can submit just using claims, so you don't necessarily need to have an EHR in order to submit or in order to track your measurements. So there are, some things that you can do in the short term to kind of avoid that negative payment adjustment, at least initially. But over time, it's going to get harder and harder. So that performance threshold is going to increase, and it's going to get kind of harder to achieve that minimum, without an EMR system. So.
Okay, great. And then we have a couple of questions around reporting and how to register and start reporting. Let me read this one off and we'll see if this one gets us to where we need to be. How do you register or start to report on the base questions? Is there a list of instructions somewhere? This particular person says we participate in Medicare ACO, so we will be reporting for the first year.
So registering to report. So you don't need to register necessarily to report. And that's a good question. I've gotten some questions in the past about if you need to register if you're part of a group. So the only thing that you need to register for ahead of time is if you are part of a group and you want to use this CMS web interface. So if you are a group and you've used the GPro tool in the past to report for PQRS, then that's the only thing you need to register for. Otherwise, you don't need to register for anything. You just kind of report however you want to report when the performance year is over. If you're a group and you're going to be reporting using a registry, you don't need to tell anybody. You can just use your registry and report at the end of the year.
Okay, great. Thank you. This particular question is around patient-centered medical home and is regarding how would we know if we participate in a patient-centered medical home? Any advice you can give there?
So the definition of patient-centered medical home that CMS uses in order to get kind of that 100% in improvement activities is fairly broad. So that kind of would encompass any kind of certainly federal model that's, dubbed a patient-centered medical home, or, a regional model or a state model. So it's kind of broad what CMS will allow. The definition of patient-centered medical home is fairly broad. So certainly, a practice manager or anybody like that, I think they all involve some kind of, formal contractor registration. But again, kind of anything, a local model, state model, regional model, CMS is kind of allowing for a broad range of models to be considered a patient-centered medical home.
Okay, great. I know we have about 2 minutes left, and we do have some other questions, but we will follow up in an email after with answers to these questions since we are coming to the end of our time here. There was a couple of questions I saw about sharing, will we share the slides? They are available in the resources section on your screen in PDF form. And then we have recorded this presentation and we'll be sending out a link to the recorded webinar as well. So both of those options are available to you. Just to wrap up quickly, thank you again to in our question and answer section here to Kaitlyn for getting to those questions. So we are at the end of that. Let's see. We do have some upcoming educational events coming up soon that I want to go over with you here in just a minute. We have next week on Thursday a webinar, Thursday afternoon, March 2nd, with Health System CIO, and we're going to be talking about optimizing your mobile device strategy. So that'll be a great one, talking about mobile devices and how you're using that in your setting. And then coming up at the end of March, on March 28th, for physician practices and how to create a high-performing practice. So links to those links and registration to that will be coming available. And you can always check that out on our website at perfectserve.com in the Knowledge Center. I'd like to just thank Kaitlyn Greenbaum and Michelle McCleery once again for an amazing presentation today. Thank you so much for your content. And thanks to our audience for joining us. We know your time is valuable, and we appreciate you spending time with us. Please do take a moment to complete our short survey and tell us how we did, and have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by.